My name's Jim Leffler. I'm going to be teaching a 14-week course on psychodynamic psychotherapy technique. It'll be 14 classes. My goal is to introduce residents, y'all, to an alternative way of hearing. I've often heard psychotherapy described as talk therapy. I actually think of psychoanalytic psychotherapy as a listening therapy. And I'm hoping to help teach y'all how to listen over the next 14 weeks in a different way. That may sound corrective, as I just said that even out loud. It's not meant to. It's meant to offer a binocular vision. Y'all are expert at doing many things in terms of formulating a psychiatric understanding of a patient, providing a psychiatric treatment plan, and I don't want to take anything away from that. It's quite impressive. I just want to add a different way of seeing and a different way of listening. So I also want to kind of define psychodynamic psychotherapy as different than, say, CBT. I'm choosing those two because they're two of the more popular, more commonly used therapeutic psychotherapy interventions. So CBT, or cognitive behavioral therapy, a therapy developed cognitive. You could put in the name Aaron Beck there. It came in with cognitive theory. And behavioral, you can put in the name Skinner there. And then they get combined, and so you have cognitive behavioral therapy. And CBTs are generally agenda-driven, so there's kind of a list of things one is going to review. They are structured. They are present, focused on, say, maladaptive thought patterns or maladaptive behaviors. And the mechanism of action, so to speak, is a collaborative problem solving often, or reframing, maybe a different way to say the same thing. They utilize homework and home practice, and they focus on thought and the idea that one can change one's thought, and that will change kind of one's emotional experience and one's behavior, or you change behavior to change one's emotional experience or thoughts. The results then are generally symptom reduction, and those can, one way to think about it is you follow a PHQ-9 and see if that changes across time, or a GAD-7, or a number of other symptom-orientated measures. So objective, agenda-driven, symptom reduction. Psychoanalytic thinking approach is a depth-orientated, patient perspective, patient-directed, exploratory kind of engagement. And the exploration is of relational dynamics, emotional processes, or attunement to the therapeutic process. And over the next 3 weeks, I'm hoping to introduce what I mean by patient perspective. The depth-oriented would be kind of all three of these rolled into one. Patient-directed, meaning hopefully we'll talk about that next week in terms of frame. There are certain things that are set within a psychoanalytic, psychodynamic frame. And then what do we explore? And hoping to then spend the third session and thereafter looking at how do we explore it from a patient perspective within the patient-directed frame. I'm using the word psychodynamic and psychoanalytic interchangeably as I'm speaking to you. I see this approach as something that can be used whether you're seeing someone 4 or 5 times a week, laying on a couch in a classical psychoanalytic tradition, or whether you're seeing somebody for the first time in an emergency department or inpatient unit, or you're seeing someone every 3 months in the outpatient world for medication management, or weekly. So I'm attempting to provide you with a new way of listening, and it may not be new to everyone, but recognizing it is an approach that can be leaned on and utilized and incorporated into any treatment session, not only a classical psychoanalytic case that's 4 or 5 times a week. Admittedly, today, like in 2026, psychoanalysis is technically defined by meeting someone in this setup 3 times a week. So let me just give a hypothetical patient situation. So you have a patient, you've been seeing this patient for a couple of months, they're telling you about one of their friends who's going through a divorce, and they're kind of talking to you, and then they say, why am I even telling you this? And that question can bring up a number of different responses. Any of the four that I'm about to describe could be psychoanalytic, depending upon what's necessary for that patient at that time. Why am I even telling you this could be read as information that the patient really wants to clarify their goals. Can we explore why I may or may not be telling you this? Is this necessary or not? You could offer reassurance and say to the patient, it's often you kind of forget what's important to you, and this friend of yours is very close to you, and that's why you're telling me. You could name the shift. That might be more kind of classically what's called a defense analysis, where the patient's speaking along, they're freely going along, then all of a sudden there's a shift to this other element away from the story, now to the interaction between you and the patient. And you might just point that out and ask them to be curious about why there was a shift. You could also be silent. The silence can bring up a lot. It may be more directed actually at yourself, so you can take a beat to wonder, maybe this was a bit accusatory in that I actually wasn't listening just now, and I need to kind of look inside myself. Or maybe something else is coming up between us. Can I get closer to an emotional register? Any of those four things are possible, and it's just kind of thinking about what to do now. And that's why we have to kind of stay attentive to where the patient is at. So we're going to try to be able to develop a way in which we listen with a third ear. And another way to frame what I've been talking about today is there's a diagnostic listening and there's a dynamic listening. Diagnostic listening I think of as kind of third person or objective or high level view. An example of this is going to be the difference between, say, map view, which in this analogy, that's diagnostic listening, versus street view would be dynamic listening. And on the map view, say in Google Maps, not that I'm endorsing one map program over another, you could have the intersection of Main and First, and you'd notice there's a post office in this corner, and then the left-hand side here, you've got the school, and then directly opposite that, a town hall. And then you can use your mind and say, well, I know if there's a post office, a school, and a town hall, and there's a Main and First Street, that likely means it's a town. So you've now taken the elements of this map and turned it into your known understanding of town. And this is what y'all are excellent at doing at this point. You can take symptoms, such as SIGI caps. You recognize that the presence of those symptoms, 5 of those symptoms, for 2 weeks is major depressive disorder. And I am not taking anything away from that. It's necessary, it's life-saving, it's helpful, it provides treatment plans. I'm just offering that perhaps in dynamic listening and in psychotherapy, there could be another way of approaching a patient, which would be a first-person point of view. And what do I mean by this? We're trying to understand the person where they're at. So if you've met anyone and they say, I'm anxious, that can mean a whole number of different things. And while I don't want to ever discount someone's attempts to explain that or share that with me, it often is really hard to know what somebody means when they say that. So it takes time to understand what their anxiety is. That the human body is fairly unsignificant, differentiated in its way it describes something. For example, I can have an experience where I'm about to die from a physical ailment, and I can feel this fear arise, and I can have a similar kind of experience whenever I have made a mistake during public speaking. And they can feel the same, and it takes time to differentiate out what the body's telling me, what my experience is. And so we're trying to get into the mind and experience of the person in front of us. And just to give another way of saying this, so the top view here, from an objective third-person map view, I would say, well, I see a person standing in the foreground here, and then a child on the ground looking up at the person. another person here, person B, looking straight on at the person, and another person here has gone up these steps and now is looking down from above on this person. And that's my objective kind of diagnostic way of describing what's happening. But from a different perspective that's as equally important is if I take the perspective of A, this is what it would look like. They'd say, I see a lot of grass and I see the top of this person's head. From the perspective of B, well, I see this person's head, I see the sky, and I see the grass. And then from C, gosh, I see a whole lot of grass, and then I see this person's torso, legs, and feet. All three are correct in a way, and neither is superior to the other, just as the top view isn't superior to the bottom views. We're just trying to add the bottom views so that we can gain the perspective of the person, and possibly from our entering into that can maybe help highlight other elements of what's going on. Oh, well, tell me more about the sky when they may be very focused here on the ground, or tell me more about the top of the person's head than the grass, etc. So the psychoanalytic attitude that I'm hoping to impart, and we will be focusing a lot on in-class exercise, is curiosity in place of certainty, and to symbolization, meaning trying to take experiences people are having and try to understand what are they saying and telling us, the tears, the shift in tone. We're trying to work with people on a narrative creation. So here, A, B, and C all have very different understandings of the world, and we're trying to give voice to that and help them become authors of their stories instead of feeling often like characters within it. And then it just requires, I wrote patient listening, intentionally meaning we're trying to listen to the patients and we're trying to do it patiently. All right, look forward to talking with you in class.